approximately half of the test, 50% of the test is coming from chapters 43 and 44, so the stuff we're talking about now. The stuff when we do the review day will be stuff we've talked about previously, just to kind of bring that stuff back to the forefront. All right, so chapter 43 is all about lung expansion therapy. So where we typically, and again, this could be for a great number of patients, but where we typically would encourage one to use lung expansion therapy are our post-operative patients, especially patients with chest, thorax, or abdominal surgery. Picture you've had surgery to your chest, your abdomen. Physician did whatever they had to do. The surgeon did whatever they had to do. They took out, they fixed, corrected, whatever, and they put you back together. And here you are post-operatively. And now you're going to breathe. And you're going to take some deep breaths. And are you going to cough? Probably not, because it's going to hurt. It's going to be uncomfortable. And so you think about these patients, post-operative patients, breathing shallowly, not taking deep breaths, not coughing, etc. So the incidence of atelectasis, what does atelectasis mean? Lung collapse is more likely to occur among that type of patient, that patient population. Those that are not able to take a deep breath, or who can't take a deep breath, or who choose not to take a deep breath, again, post-operatively because it hurts. You know, these patients with atelectasis will probably become hypoxic, so they'll probably need some oxygen. It puts them at risk for nosocomial infections like a nosocomial pneumonia, because again, they're not taking deep enough breaths to cough, and potentially acute respiratory failure. And so lung expansion therapy, the topic of this entire chapter, is dealing with this sort of situation, this sort of patient population, if you will. All right, so we'll talk about several of these things today, the different types of lung expansion therapies we can provide our patient. So some of the names here: deep breathing or directed cough or directed coughing. Yes, it could be as simple as that. Okay, patient, I need you to take deep breaths and I need you to cough. Now, some people can follow that instruction precisely. Some people can say, okay, I'm going to try, but their efforts are not very good, they're weak, or again, painful, because again, it hurts. Incentive spirometry, something we'll talk about today that we can encourage. And incentive spirometry is just a fancy way of having the patient breathe deeply. The only thing is they get some visual feedback to let them know they're breathing deep enough. IPPB, which stands for intermittent positive pressure breathing, that's a therapy we can provide to assist with lung expansion therapy. IPPB, intermittent positive pressure breathing. We give the patient a positive pressure breath, just like a mechanical ventilator delivers a positive pressure breath, and it forces the patient's lungs open, forces the patient's lungs to expand. CPAP therapy, continuous positive airway pressure, similar concept with pressure. PEP therapy. PEP stands for positive expiratory pressure. Those are some strategies, some things we can do to lead to lung expansion therapy. And the chapter even mentions the high flow nasal cannula as a means to provide lung expansion. We won't get so much into that and its purpose of lung expansion, but the theory behind it is, with all this flow going to the patient, when the patient exhales, they exhale against this high flow, could create back pressure. There's your lung expansion concept. All right, so why do we do lung expansion therapy? To prevent or to correct atelectasis. So again, we could use it to prevent it, or we could use it to treat it. Again, atelectasis. When we increase a patient's lung volumes, what we're actually doing is increasing their functional residual capacity. That goes back a few weeks. Remember the lung volume capacity chart where FRC fits into play? Anybody remember where FRC is in the lung volume capacity chart? After a normal exhalation, what's left in our chest after a normal exhalation is our FRC. And so we're doing this therapy to try to increase a patient's FRC. not so much yours and mine, because our FRC right now is normal, but that patient who has atelectasis, who is breathing shallow, who can't take a deep enough breath, their FRC is probably getting smaller and smaller and smaller. And so that's why we're doing this therapy, to help increase their FRC. All right, so two fundamental types of atelectasis, and again, I know we already defined atelectasis as collapse of the airway, or collapse of the alveoli, or collapse of the lung, but two different types. Gas absorption atelectasis. This is a type of atelectasis that occurs when there's interruption of ventilation, either to a section of the lung or if there's a significant shift in ventilation perfusion. Any gas distal ends up being absorbed by the bloodstream. Again, removing the gas that's in the alveoli or in the airway at that time. Leading to the term lobar atelectasis. Now, the most common cause for gas absorption atelectasis would be a mucus plug. Mucus obstructing that airway, impeding ventilation to go to that particular section of the lung. If we have a giant mucus plug in our airway and gas can no longer get to that passage, the gas that right now is in that air passage, in that alveoli, will be absorbed into the capillaries, will be absorbed into the bloodstream, leaving nothing in that section of the lung, and that's why that lung collapses. Gas absorption atelectasis. The other one is compression atelectasis. Again, decrease in the transpulmonary pressure. Now, this goes back several weeks too. What was the purpose of the transpulmonary pressure gradient? Isn't that the pressure gradient that keeps the lungs open? Okay, so if that pressure decreases, that pressure gradient decreases, what happens to the lung? Instead of the lung being open, the lung begins to collapse or close. Common when patients are experiencing general anesthesia. Remember, I used the term post-op patients previously. Again, patient, even after they're coming out of surgery, may still be under the effects of anesthesia, not taking deep breaths, not breathing very deep. Those same patients are going to be the ones who are receiving what? Narcotics, sedatives, keeping them comfortable, trying to keep them pain-free. And yes, they need to be on those medications so they aren't hurting, so they're not in pain. But that's going to cause them to breathe how? Probably more shallow. Bed rest, lying in bed, prolonged bed rest. Are you going to be taking very deep breaths? No, that's going to lead to atelectasis. Morbidly obese patients, may be difficult for them to take deep breaths. And then again, when deep breathing is painful. Again, those post-op patients. Maybe it's a patient with fractured ribs, or thoracic or abdominal surgery. And I should have mentioned this before. When I say thoracic or abdominal surgery, so chest or abdomen, but the closer that surgery is to the diaphragm, the greater the risk for atelectasis. Okay, so if the surgery's, in the abdominal cavity, lower thorax, closer to the abdomen, or that muscle is going to be working to breathe or to deep breathe, the closer that incision, the closer that surgery is to the diaphragm, the greater the risk of atelectasis. So these things will cause the patients just to do what? Breathe shallowly, small tidal volumes. And over time, just breathing shallow. And again, picture that patient, just prolonged bed rest patient who's not taking deep breaths. What happens to the lung over time? It eventually collapses. All right, so different factors, I think we mentioned several already, that are associated with atelectasis, so significant obesity, neuromuscular disorders. We'll talk more about what neuromuscular disorders are next semester, but these are the disorders that can affect the muscles, the ability of the patient to breathe, or the ability of the patient to breathe adequately. Like I said, we'll talk about several of those next semester, but any of those disorders can cause the patient not to be able to breathe deeply. Patients under heavy sedation, surgery near the diaphragm, as I mentioned before, prolonged bed rest, a patient with an ineffective cough. Again, go back to that post-operative patient. Again, they don't want to take a deep breath. They don't want to breathe deeply. They don't want to move any mucus, and sure as heck, they don't want to cough. They end up with retained secretions. Now they have a pneumonia, and again, making things 10 times worse. History of lung disease. Again, especially if the lung disease is affecting the lung parenchyma, the lung structure itself. And then of course smokers. Smokers are going to be on probably every single list somewhere, but they obviously are going to have issues related to their lungs. Rule of thumb here, I kind of took this right out of the textbook. Direct relationship between spontaneous respiratory rate and the degree of atelectasis. The more atelectasis is there, the faster they're going to attempt to breathe to try to make up the difference of the volumes they're not lacking. Again, the body is a beautiful thing. It will try to still maintain the same minute ventilation, even though the tidal volumes keep getting smaller and smaller because of us breathing more shallow. All right, just some clinical signs here of atelectasis. So history of major surgery, again, most likely that could be that patient, especially if that surgery incision happened to occur close to the diaphragm. Patients who are tachypnic, patients who have tachycardia, so increased respiratory rate, increased heart rate. Breath sounds, they could have fine, late inspiratory crackles. They could have bronchial breath sounds, or even more appropriately, diminished breath sounds, again, because they're not moving a whole lot of air. History of chronic lung disease, smokers more prone to respiratory complications such as atelectasis. If we look at their x-ray, again, if air is appearing darker in color, these are areas that are going to appear more white in color. So what's that word? Radiolucent or radio-opaque? More radio-opaque, indicating lack of volume. I think in this one in particular, it was kind of this lower region of the patient's right lower lobe where atelectasis was beginning to develop. Could cause the diaphragm to shift further upward. If again there's lack of volume here, the diaphragm could shift upward. And if the atelectasis is significant enough, it could cause the tracheal midline to shift. If the atelectasis is significant enough. This one I say it's not significant enough. The trachea is fairly midline here. The patient is rotated, so it's not the most ideal x-ray. But if I give you this x-ray, you can see that black arrow pointing to the shift where the atelectasis is, and the atelectasis will do what to the trachea midline? It will pull it toward itself, right? Atelectasis will pull it toward itself, whereas a pneumothorax will push it away. All right, so I have this here for a reason. I'll go ahead and read it here. So how does the patient with atelectasis present during a physical assessment or physical exam? Well, depending on how severe the atelectasis is, the patient could be lying in bed, start to need supplemental O2. Again, remember this is the atelectasis is developing. So right now, they were on room air previously, but now they're needing some O2. On auscultation, breath sounds can range from shallow to distant. When asking the patient to take a deep breath, you may hear faint crackles and see, during deep breathing, improvements in oxygen saturation. That may be our first clue that maybe with normal breathing, they're developing atelectasis. Moderate atelectasis can present itself with an increased respiratory rate and consistently lower oxygen saturations, which turns to, now we need to give them more and more oxygen or higher concentrations of oxygen. Breath sounds may have definitive crackles, and you may also hear occasional bronchial breath sounds. Severe atelectasis can present by having the patient complain of dyspnea, requiring even higher amounts of oxygen, and having now absent or significantly diminished breath sounds over the affected area with distant bronchial breath sounds in the surrounding margins. So I just wanted you to kind of see, especially the lack of oxygen or the desaturation. The more the atelectasis continues, the lower the sats can go. Now the patient complaining of shortness of breath. And again, what's our initial remedy? Well, let's just give them some more oxygen. We started with room air. We moved to 2-liter nasal cannula. We moved up to 4 or 5 liters nasal cannula. Now we're pulling out a Venturi mask or air entrainment mask, maybe even a non-rebreather when things are getting down in the severe stage. Again, and we haven't done anything to correct the problem in the first place, the atelectasis. All right, so before beginning therapy, some baseline assessment stuff. So general evaluation of the patient's clinical status, their vital signs, of course, patient appearance and sensorium. Sensorium is important because some of the things we will be instructing the patient to do does require their comprehension and knowledge of what we're doing. There's some things we will instruct the patient to do, there's things we'll have the patient perform for us, and then we may turn it over to the patient for a time counting on the patient to perform that therapy even when we're not in the room. So knowing sensorium will let me know if the patient's even able to do that or even able to participate in that themselves. Chest auscultation, the breathing pattern, patient's level of motivation and ability to follow instructions, again, is going to help with the therapy that I'm electing to give them or electing to perform with them. Are they able to follow our instructions? Are they able to do it even when I'm not in the room if we select one of those types of devices? All right, before we talk about the different types of therapies, we should always not forget. And again, I know a lot of times the staff hates it because, boy, the patient's so much easier for us to manage when they're just lying in bed. And we're not having to get up out of bed, just lie in bed. Just quit calling me, just stay in bed. It'll make my shift go easier because I'm not going to have to be there to assist you in getting out of bed. Yes, I get that. That all makes total sense. But the sooner, the more we can get that patient out of bed walking, how do you think you would breathe lying in bed, not moving a muscle, watching TV, that's all you have going on right now, or reading a book or playing on your phone, versus getting up out of bed, walking, and again, it's an encouraging thing to be able to walk from the bed to the door, to the hallway, and maybe that's all the patient can do right now. You know, think about how their breathing would be. Would they be breathing deeper? Yeah, more than likely getting out of bed. Now, if they're able to get to the door, to the hallway, and they're still capable, they're not short of breath, they're still doing, hey, wouldn't it be great if they can take a few steps down the hall, either way, maybe do a lap or two. Again, think about how their breathing is going to be during all of this. They're going to be breathing deeper, trying to correct the atelectasis, or maybe prevent the atelectasis from happening in the first place. So we always can't forget some of the obvious stuff. The sooner that patient can ambulate, the sooner that patient can get out of bed, it's going to help them take deeper breaths, and it's going to improve their overall health anyways. And yes, I get it. The patient might not be able to do this on their own solo. They may need assistance in helping them walk. And yes, it becomes time consuming for the staff to have to do that, but again, maybe we can get the patient's family involved, get them to help us, get them to help the patient move. Okay, we're going to walk you right now. You seem to be pretty stable and steady on your feet. I'm not going to let you go, and obviously not going to let you fall. Let's see how you do. You did pretty well. You're back in bed. Hey, great, your family's here. Maybe later this afternoon you guys can do this too. Just to get them out of the bed. OOB?
Out of bed.
Thank you. Out of bed. Out of bed. Even, it might not seem like a big deal, but getting them out of that bed into the chair is a huge milestone, is a huge step. And there's other reasons. Obviously, my reason seems to be more for preventing, treating atelectasis, but think about bed sores and stuff like that. Going to be not lying in the same position, same spot in the chair that's right next to the patient's bed. But you may be interested to note, we will have mechanically ventilated patients ambulating. ET tube, circuit, ventilator. Somebody has to push that ventilator. That's what I'm going to do. Hurry up, patient. You're going to fall behind. And it's quite unusual when we typically think about a ventilator patient being in bed, not moving a muscle until they're well enough to be extubated. No, we'll get some of those patients out of the bed and moving. Yes, they're not doing too many laps with an ET tube in place and a ventilator, but every little bit helps. All right, so let's talk about the different therapies, all right, for lung expansion. And remember, and sometimes people get these therapies confused with what we'll talk about when we get to chapter 44, the airway clearance therapies. Okay, so these are strictly lung expansion. All right, the first one is incentive spirometry, or IS for short. Now, you don't hear this term used a lot clinically, but you hear this term used more NBRC world. To coach the patient to take a sustained maximal inspiration, SMI, sustained maximal inspiration. That's what we have them perform. The proper technique to do an incentive spirometry maneuver is to have them perform a sustained maximal inspiration. But that SMI is usually something you don't hear mentioned clinically. You could tell a patient that, and they're going to go, okay, well, what is that? Okay, what is, and I think I get it, but what is a sustained maximal inspiration? So, this is the technique. The first step is extremely important. And I say this because a lot of people get it wrong. From a resting normal exhalation. So how do you do a normal exhalation? You just exhale. Pause right there for a second. Normal exhalation. Then taking a slow, full, complete deep breath followed by a breath hold. Now I'm not as hung up on a time here like I would be for an MDI or DPI with a 10-second breath hold, but some breath hold, okay? And that's the maneuver. You just did an SMI. Normal exhalation, full sustained, maximum deep breath with a breath hold, and then exhalation. Okay, that was just one. We're going to do more than one for our patient, but that was just one as an example. But let me tell you where people get this wrong. They get it wrong with the very first step. Some people will tell the patient, take a full and complete exhalation till you're completely empty. Then take a big deep breath in and do everything else we just said. That's the wrong technique. Now you may, because what we're going to do here with the incentive spirometer is we're actually going to measure volume. We're going to see how much the patient's able to take in. And we'll encourage them, whatever they're taking in right now, we'll encourage them to do more. And we'll push them to do a little bit more after that, and a little bit more after that. And so if we're measuring volume, I will say this, you'll actually see a larger number if you tell the patient to exhale fully and completely and then do the deep breath in. But that's not the technique. The technique is to do a normal exhalation. The reason we don't have the patient do a full and complete exhalation is because why are we doing this in the first place? What are we treating and or preventing? Atelectasis. What do you encourage for your patient who has atelectasis or may have atelectasis when you tell them to exhale completely? Collapse. You're encouraging atelectasis if you tell that patient to exhale completely. So that's why you want to keep them exhaling just normally. Normal exhalation. Then get them focusing on taking that big sustained deep breath in. Okay, so don't forget the first step. And you know, and I'm telling you this right now, when I ask this question on the test, I'm going to give you the obvious right way, but I'm going to give you the wrong way too. And how am I going to phrase the wrong way? Take a full and complete exhalation, followed by the maximum big deep breath in with a breath hold. Okay? It's a normal exhalation first. Okay? Everybody understand? Everybody kind of get that concept? Because you're going to have, no offense, you're going to have another RT, you're going to have a nurse, you're going to have a doctor come in and say, well, here, let me show you how to do this. And I'm real cocky and really arrogant. Let me show you how to do this. Your patient's pulling X number. I'm going to make them pull in more. And they tell them, take a full and complete exhalation. Of course the patient's going to do more because you had them start exhaling more of what was in their lung. But again, what are you encouraging when you tell the patient to fully exhale? Atelectasis. You're encouraging the lungs to collapse when you completely, fully exhale. So we will instruct them, exhale normally. Then the big deep breath in with the breath hold. The incentive spirometer does provide some visual clues. Again, all we're doing is teaching the patient, coaching the patient to take a big deep breath in. But the incentive spirometer gives them some things to look at, to let them know, okay, you're breathing in deep, or you're breathing in too fast or too slow perhaps. So it's giving some feedback to the patient on how they are breathing in deeply. And this is proved to be effective, especially in the high-risk patients. Who's the high-risk patient? Who's the high-risk patient? Every other time but. I know. The post-op patients. And again, what type? The guy who had his foot done? No. The guy who had his hand put in a cast? No. The person who had chest or abdominal surgery. That's the high-risk patient this therapy would benefit the most from. All right, so indications. Presence of atelectasis. So again, they have it. They have it. We see they have it. Okay, so I'm going to encourage this deep breathing so the patient can help to open up and recruit their own alveoli. Number 2 here, presence of conditions predisposing the patient to atelectasis. Again, that post-op patient, that patient who has been lying in bed for extended periods of time. Yeah, maybe that surgical patient who did have a pulmonary history would benefit. Patients maybe with quadriplegia or a dysfunctional diaphragm. Maybe some of those neuromuscular disorders that can lead to impaired breathing could benefit here, could be an indication for incentive spirometry. Now, contraindications. What's a contraindication?
The downsides.
Okay, so when you shouldn't use it. Okay, when you shouldn't use it. Now, these are not as necessarily, I guess, as, I don't want to say these are harmful things, but these are things to understand. So when incentive spirometry should not be used, or probably wouldn't be of benefit. Patient who can't be instructed, supervised to ensure appropriate use of device. So this always, it makes me laugh and be sad all at the same time. I have a patient on my work list, a patient I'm going in to see today, and the only therapy I'm performing for this patient is an incentive spirometer. Was told in a report, patient already has an incentive spirometer in their room. They've already been coached. Okay, it's fine. Right, so I don't need to bring one, no, the patient already has one in their room. Okay, I go in the room, knock on the door, introduce myself, come to find out the patient is comatose. There's an incentive spirometer at the patient's bedside. Yep, they do have their own spirometer, but I promise you, this guy, and how long has he been comatose? How many weeks? Okay, and you guys understand what comatose means. They're still breathing on their own, but there's just no interaction. They look asleep, they appear asleep, they're not waking up even if I'm jostling them in bed. And yet there's an incentive spirometer at their bedside. Great, maybe that's protocol because of whatever was going on with this patient. They had to have an incentive spirometer, so somebody brought it to them, but I sure know this patient was never instructed, or if they were, the patient didn't comprehend what they were instructed, and there's no way in the world this patient's able to do the incentive spirometer. Now there's some other therapies we'll talk about shortly that we could do with that patient, but I promise you incentive spirometer is not going to be the thing that's going to work for this patient, because the patient can't actually perform it. It kind of leads into number 2. Patient cooperation is absent, or they're not able to understand the instructions. They're not able to demonstrate it. Now, go back to the maneuver. What do you coach the patient to do? After a normal exhalation, take in a slow, deep breath with a breath hold. I've had patients, and I've been the one to instruct in the beginning, so I'm not faulting anybody else. I instructed this patient in the beginning. Early this morning, it's later in the afternoon, I'm seeing this patient. Maybe they're on my breathing treatment list, so I didn't see them. But early this morning, now it's in the afternoon, I'm backing in with another breathing treatment, and I mentioned, oh, remember I was here this morning? You've been doing that incentive spirometer, haven't you? Oh yeah, absolutely, just like you said. Okay, good. Well, while I'm in here and we're wrapped up with this nebulizer treatment, why don't you go ahead and do a few breaths so I can chart it, so I can document it? Okay, sure, here you go.
In there.
They blow out. I know for a fact. You did it right this morning, but right now you're blowing out like you're blowing candles out. All right? That's not, and again, I always try to be encouraging where I can. That's not bad, but remember, this is the thing you actually breathe in, not out with. Oh, okay. And it always makes me wonder, was the patient doing this for the last 4 or 5 hours? Every hour on the hour like I instructed them to do? 5 to 10 breaths like I instructed them to do, but instead of breathing in, they were breathing out. Or this last bullet point, if patients are unable to deep breathe effectively, it does require the patient to have some sort of effort for this to be beneficial. And so remember this number, if their vital capacity is less than 10 mLs per kilogram, this therapy, incentive spirometry, is probably not going to be beneficial. Because this means the patient really can't take any deep breaths. And for this device to work, they have to be able to take deep enough breaths. or an inspiratory capacity of less than a third of predicted, and that's fine too. But my focus is what I've put on here and highlighted here and put in bold. If their vital capacity cannot be at least 10 mLs per kilo. Just so you guys are aware what your and my vital capacity is right now based on our ideal body weight. Ours is about 65 to 75 mLs per kilo. And that's me and you, perfectly healthy. So when we say they can't even do 10, that's very, very low even from normal, okay? If they can do 10 or higher, okay, we can, thumbs up, we can do incentive spirometry, and it could be beneficial for this patient. But if they can't do at least 10, then this therapy needs to be pushed to the side, and they need something else. They need something different. All right, hazards and complications. Again, generally pretty well accepted, but if you were to really look at the literature and really try to research to figure out, well, what are potential complications or hazards here? Hyperventilation and respiratory alkalosis. And that's simply by the patient doing this too fast. This is not a patient, again, talking to the patient here, patient, this is not a race. When I tell you to do 10 slow, deep breaths, again, just because you do it, in a matter of 30 seconds, all 10 breaths, that's not what we're looking for here. Again, you're not going to get me out of your room anymore. You're not going to have to do this any less just because you do it faster. No, let's do it right. Let's do 5 to 10 good ones and do them right. And then I'll leave you be and let you finish your lunch or your breakfast or whatever the case may be. So it's easy because what type of therapy is this again? What's the general? Lung expansion, right? Lung expansion. So it's easy for them, because they're moving perhaps more air than they normally would, to suddenly eliminate lots of carbon dioxide, hyperventilation, and again, eliminate lots of carbon dioxide, leading to a respiratory alkalosis. That's why I say most common problem, if you want to call it that. And it's just simply the patient's doing this too fast. Again, this is not a race, this is not a rush. Discomfort secondary to inadequate pain control. Again, picture perhaps our ideal patient population here. Chest or abdominal surgery, I'm making them deep breathe. It's uncomfortable for them to deep breathe. Well, maybe if I could time my time in the room to occur maybe 20 or 30 minutes after the patient received pain med, as opposed to giving this treatment 20 or 30 minutes before they're due their pain med. Again, just can kind of work that out with the nurse. When would probably be the best time to have this patient do some deep breathing? So that could possibly occur. Pulmonary barotrauma would be very rare, but again, patient pulling in too large of breaths, already someone like maybe a COPD patient that already has fragile lungs to begin with, but that's still very rare. Exacerbation of bronchospasm, would see that more with an asthma patient, again, just because they're taking in this deep breath, it could kind of set their twitchy airways off. And then fatigue. Again, I'm not saying you would be fatigued or I would be fatigued, but your patient, again, maybe doing this the first few times, could get a little tired from doing this. But again, what are we trying to mimic? Deep breathing, the same kind of deep breathing they would have if they were walking up and down the hall. All right, so here's the device. Again, there's different brands. Each one has a little bit different look, but fundamentally they're all about the same. Small, simple, portable, inexpensive. This is something, especially if it's a post-operative patient. Hey, I hear you're getting discharged today. That's great, wonderful. Hey, that's yours. Take it home with you. Stick that in your bag. Don't leave it here because we're going to throw it in the trash. That's yours. Take it home. You could do this at home for the next few days until you're feeling back to 100%. They make them either flow or volume oriented, even though the flow oriented ones are more typical. But what you're going to see on it, in this particular picture, there's kind of this blue piston here at the bottom. When the patient inspires deeply, this piston will rise in this larger chamber. Again, showing us how much volume the patient was able to pull. Okay? When they exhale, this will fall back down. And we'll do it slowly. So again, I don't have the patient, because again, this is not a race, this is not a rush. Allow them to exhale, allow this to fall. I've had some patients pull up maybe 1,500 and they don't let it fall. And they take another big deep breath in and it goes here and it starts to fall. They take another big deep breath and they're like, look, I'm doing 4,000. Not in one breath. right? So make sure it falls back down to 0 and then have them start again. And this is an important number because I'm going to document what this number is. I need to know how much they were able to pull with the correct technique. Now when they breathe in deeply, they need to breathe in fast or slow? Slow. This flow indicator lets us know and lets the patient know, again, these are actually visual clues not only for me but also for the patient, to let them know, hey, you did that, but you breathed in too fast. If you know what this says, it says keep indicator between arrows. Here's the indicator. When they breathe in, this will start to float and hover as they're breathing in. If they breathe in too fast, this will shoot to the top. Again, letting us and the patient know, hey, that was too fast. It needs to be slow. So when they start to breathe in, again, this is a flow indicator. We'll just kind of hover it here between these two arrows. Lets us and the patient know they did it at the right speed, slow enough. And as they're doing that, again, that flow as they're breathing in, and that's hovering here, you're seeing volume that they're pulling in go up in this larger chamber. There's also, and again, everyone looks a little bit different, but they also tend to have some sort of marker that I can adjust, and that's my clue to the patient, hey, this is what I want you to do right now. I want you to do 1,000 mLs as you breathe in. If I notice the patient's doing 1,500 mLs, guess what I'm going to do to this indicator? I'm going to pull it up a little bit, and I'm not going to leave it at what they're able to do. I'm going to push them a little bit higher. I do want to make sure what they're doing is obtainable. I don't want to see a patient doing 1,000 and I say, okay, well, this is what I want you to do, 4,000. You know, if the patient only can do 1,000, that's not very encouraging to the patient going, I'm never going to make that much. You know, so I will tailor it to what the patient's able to do. If they can hit 1,000 consistently, then I may put that indicator and say, okay, I'm going to put it right here, kind of the midway point between 1,000 and 1,500, and say, okay, there's 1,250. That's what I want you to be able to do. Next time I come in here and see you in a few hours, that's what I want to see you being able to hit. Or tomorrow when I'm back, that's what I want you to be able to do. And when tomorrow they're able to do that, okay, great, that's a good job. Now I'm going to tweak it up a little bit more to keep pushing them to do higher. Again, ideally, patient sitting upright. Again, that doesn't really do well if they're lying on their side. So sitting the patient upright, focusing on taking a big, deep breath in. You know, exhale normally, but a nice, full, big, deep breath in. You can see this indicator kind of has a yellow piece. I'll show you an example here. This particular one has a good, better, best window. So instead of the arrows, as you pull in, it wants you to kind of hover it more here as opposed to here, even though this is acceptable. But if you pull in too much, it's going to shoot above it. That's not where we want it. We want it hovering in this area. Again, you can see where the marker is indicating where we want that patient to perform. We do not have a lab this Friday, but next Friday we'll be labbing this. I'm curious, Desmond and I always have a bet who has the most hot air in this room, who could probably pull in the greatest volume. Okay, we have a whole trophy set up and everything. No, I'm kidding. But
So we'll actually be doing that?
Yes.
Like us on ourselves?
Yes.
Okay, everybody
Yes.
practice at
Yes.
home.
Yep, absolutely. See what you got. All right, so preliminary planning. Many times when we go in to perform this or to coach a patient or teach a patient this, it's generally after they've had surgery. Okay? After they've had surgery. We go in, we give them the instruction, we have them perform it. That's fine. If we know this patient's going to have a surgery that's going to significantly perhaps impact their ability to do this after, it may be a good idea to instruct the patient before surgery. And there's been plenty of times I've gone into the pre-operative area, not post, pre-operative area for a patient that's getting ready to go to surgery here in the next 20 or 30 minutes, and did a quick instruction on how to perform the incentive spirometer. And when you coach them, guess what? The patient has not had surgery yet. You can have them perform this, teach them the technique, see what they can do. So you see, hey, this patient can pull 3,000 mLs. Okay, Now we know, we'll document it, but now the patient knows, okay, this is what it's supposed to feel like. This is what you can do. And I know after surgery, you're probably going to be hurting. You're going to be a little uncomfortable. You're probably not going to be able to do as high, but that's going to be the goal. That's our goal we're going to be shooting for. So you kind of give that patient the instruction before they've had surgery. Again, would make total sense for any patient prior to surgery to have this done, so they know what it's supposed to feel like and what they physically can do. So for this to work, does require effective patient teaching. Again, we can teach them this, set an initial goal, but a goal that is obtainable. I don't want to, if they can do 1,000, I don't want to make them try to do 4,000 this time. Maybe over the next few days, I'll try to push maybe something to that level, but not initially. If they can only do so much, then again, give them an obtainable goal. That does require effort though. I don't want to make it too easy. There's a reason they've been prescribed this in the first place. We're looking for good diaphragmatic breathing at slow to moderate inspiratory flows with that sustained maximal inspiration, again, with the breath hold. Now when the patient performs this, again, we're not doing this quickly, we're not doing this fast, it's not a rush thing. If the patient does a couple of good deep breaths and needs to wait and pause a few breaths in between, that's fine, that's okay. Again, I want to see 5 to 10 good technique, good efforts. And if it means they do one, followed by just a few normal breaths right now without the incentive spirometer, and then back to the incentive spirometer to do breath number 2, that's cool. I'm fine with that, because I want them to give me good efforts, not marginal efforts just because they were tired or uncomfortable. So that's what I mean. If necessary, a patient can rest in between breaths or in between maneuvers. And a minimum, again, pulling this from the textbook, minimum of 5 to 10, but you're going to find a lot of hospitals, 10 is the minimum. But again, it just depends on the facility you're at. So 5 to 10 good SMI breaths, again, with a breath hold. And that's per hour, okay? Per hour. Now, we might not have the time or the ability to go in there every hour for all of these patients to do this. We may come in there for an initial instruction. We may come back in there 4-6 hours later, do it again so we can document what the patient's able to do. But we probably do not have the time to be in there every single hour. Remember, the nurse could be pushing this as well for the patient. But when we do turn it over to the patient, I will tell the patient, doc really wants you to do 5 to 10 of these breaths every hour while you're awake. If you're asleep, and I tell the family this, if they're asleep, let them get their rest. They need their rest. But when you're awake, go ahead and do this every hour. Sometimes I'll say, hey, just every hour on the hour to help you remember.
At my hospital, we have the patients do it 10 times every time a commercial comes on.
There you go. I'm just going to say, if you're watching TV, maybe every time a commercial comes on to do it. Just as some sort of clue to say, oh, wait a minute. And they will forget, of course. Mm-hmm. Oh, shoot, I forgot. How many commercials have passed and I haven't done it? Go ahead, here, hand me that thing. Let me go ahead and grab it. I'm sorry, Jeremy, same thing. Again, just a way to help the patient remember. Now, again, these are while the patient's awake. At night, go ahead and leave it at the bedside. No reason to do this at night. Get your rest. Rest is important too. But during those normal waking hours, get the patient performing this incentive. And again, yes, we will return. We will reassess the patient to make sure they're doing it. Make sure they're pulling adequate volumes, us setting that goal a little bit higher. And I know sometimes patients hate when I come back in the room because over time they realize, damn it, every time that guy, me, comes in that room, he keeps inching that thing up. And the patient will turn around and keep inching that thing down. Like, no, I'm jotting it down. I'm letting the next therapist know you were able to do 2,000 today. I know it's taken us a couple days to get there, but I'm telling the therapist who's coming in after me, you can do 2,000. I will have, and I hate to sit there and point fingers at any patient, but sorry, gentlemen, we're the worst. We're the biggest babies, afraid to take deep breaths when we go in there and see. And I've had plenty of 20 and 30 something year old guys that come this, oh, it hurts. And I just left 87-year-old grandma who busted her tail doing 3 times what you can do. Sometimes a little motivation, and maybe I do exaggerate a little bit, to help to push them to do better. And yeah, I get it. I know it's not the most comfortable thing to perform, especially if you're post-operative, if you had surgery. So I said sometimes if you can time it after that pain medicine, give that pain medicine some time to kind of kick in, then maybe it won't be so uncomfortable for the patient. We see plenty of open heart patients, don't we? Guess who's getting this therapy post-open heart? And again, think about those poor open heart patients, male or female. They've been cut from here to here. Their chest has been cracked open. Work's been done. Their chest has been put back together, sutures and staples. And now our smiling face comes in and goes, hey, I got something for you.
Breathe deep for me.
Yeah, breathe deep for me. Get the hell out of here. But no, and it's important because we don't want those patients, not only to develop atelectasis, but then an pneumonia, an infection. Again, they've had a major, major operation to sit there and have, setbacks. All right, I know it may be hard to see this, but in case you were curious, what you should be able to do. Okay, this is based on age and height. Age, I think you guys are pretty comfortable in seeing where your age falls approximately in this range, but in case you're curious, your height, if you're 5 feet, you're 60 inches. If you're 5'2", you'd be 62, 5'4", 64, and so forth. If you're 70 inches, that means you're 5'10". If you're 6 feet, you're 72 inches. I don't think anybody's 7 feet, so we don't have to worry about that. But you can kind of see where your magic number would be, okay? Males here, females here. So when I say, oh, I was taking care of a 30-something fella who's probably close to my height, I'm seeing something here that starts with a 3, as in 3,000. And this is the same person who can't even do 1,000. Complaining, oh, it hurts so much on my chest. Okay, but this is, here, buddy, I'm showing you what you I'm not making this number up. I'm not pulling this number arbitrarily out of the air. This is what you should be able to do. And that's why I'm pushing you so hard to get there. Again, everybody kind of see what your number is?
You use that in the lab?
Yeah, well, that's why I'm showing it to you.
Okay.
That's why I'm showing it to you, so you can kind of come up with your approximate ballpark number. Now, in the lab when we do this, and since I'm over here on the ladies' side, in the lab when we do this, and you tell me, oh, and I say, well, how much are you able to do? About 1,500. Okay, then that means you're 80 years old, and you're 5 feet. Okay, that's what an 5 foot 80-year-old lady was supposed to do. The guys are doing, oh my gosh, okay, you're a 5 foot 75-year-old if that's all you're able to do. I think in this room, and I'm just eyeballing here, I think at the minimum, everybody in this room, at minimum, there's a 2 in front of your number, right? And some of you, there's a 3 in front of that number, just so you know what you should be able to do.
We're screwed.
They're screwed, yes.
Are we getting tested on this?
Yeah, that'll be question 45 on the test. To get credit for this answer, you must be able to perform one of these numbers, right?
Hey, you actually should come up with a point scale that's for extra points.
There you go, there you go. I'll have people passing out trying to get that number.
I'll be
for points.
okay. I'm sure there's plenty of people here that can resuscitate.
Yeah, for every leader, you get an extra point. All right, let's move away from incentive spirometry, and let's talk about IPPV, intermittent positive pressure breathing. Now, this is positive pressure used to expand the lung, just like we could use a mechanical ventilator to expand the lung. This therapy was really, to be honest, one of the first mechanical ventilators that provided positive pressure breathing. Back in the 1950s, this therapy's been around for a long, long time. it's transitioned and evolved into more therapy as opposed to mechanical ventilation. So where it's used today is more therapy. And this therapy is in a state of transition, and we are doing other things using the concepts of positive pressure, but moving beyond IPPB. IPPB is a therapy that, like I said, has been around for a long, long time and is starting to fall out of favor for other newer types of therapies. But that being said, the MBRC exam still asks questions regarding IPPB therapy, so it's something you guys still need to know and still need to learn and understand. And yes, we will set this up in the lab and have it running. But I just want you to know, this is really your first introduction to positive pressure breathing, to positive pressure mechanical ventilation. All right, so indications for IPPB. These are periodic sessions of positive pressure ventilation that can be used in the treatment of pulmonary complications or exacerbations of lung disease. This therapy provides the patient with augmented tidal volumes. We can force whatever volume we want into that patient's lungs, whereas incentive spirometry, the patient has to pull it in. IPPB therapy, we will give the patient the breath. You know, so that patient who can't take a deep enough breath, or it hurts and I can't really do the incentive spirometry well enough, no problem. We have another therapy that can do the same thing. Maybe we can have another therapy that can actually do it probably a little bit better. So don't worry, you don't have to breathe in deep. The machine will breathe it in deep for you. And it's funny, remember I said, again, pointing fingers at the gentleman, we tend to be a little wimpier when it comes to using that incentive spirometer. We come in and give them one of these treatments. Suddenly, miraculously, this extra energy or extra oomph comes and goes, do I have to do this? Well, no, if you do the incentive spirometer better, then I don't have to do this therapy. Oh, well, give me that incentive spirometer. And suddenly, miraculously, they have much more energy and can pull in much more with the incentive spirometer. Because this one forces them to take a deep breath, whether they want it or not. Can be used for patients with atelectasis who are not responding to other modalities, such as the incentive spirometer, or patients who are at high risk for developing atelectasis who just straight up can't do the incentive spirometer. Remember I used the example of a comatose patient that was supposed to get incentive spirometry. There's no way this comatose patient is going to be able to do this. Well, we can do this technique instead. Patient will still have to breathe, obviously, but the IPPB machine will deliver the breath for the patient.
Will deliver the tidal volume that you set for.
Correct, correct. We'll deliver that volume that we want that particular patient to take. All right, so contraindications. Now this is important because we are providing positive pressure ventilation. Positive pressure isn't always a good thing. Sometimes too much pressure can cause problems. So be careful when we are doing this, and especially, and we'll make sure we're mentioning this in the lab, but if we're doing this to each other or to yourself, be very careful how much pressure you're giving yourself, because you can, even for a normal lung, pop a lung from giving too much pressure. So the first thing here, these are all contraindications, but the first one is the absolute contraindication. Now when you see the term absolute contraindication, that means you are not giving the therapy. You cannot give this therapy with this condition. The other contraindications, you have to weigh the risk-benefit. But an absolute contraindication means you are not giving it. So the only one true absolute contraindication to IPPB therapy is a patient with a pneumothorax, an untreated pneumothorax. Because you know what happens if they have a pneumothorax and they don't have a chest tube in place? What's going to happen to their pneumothorax if you give that patient positive pressure? You're going to make that pneumothorax even worse. Okay? All that pressure is going to go into that pleural space and make that pneumothorax 10 times worse. So until they have a chest tube in, once they have a chest tube in, then that absolute contraindication turns into what we call a relative contraindication. You can give it, but being very cautious with it. But the absolute contraindication means there is no way you're giving this therapy for a patient with an untreated pneumothorax or untreated tension pneumothorax. Now the other things, again, would be considered relative contraindications. You gotta weigh the risk-benefit. Patients with elevated intracranial pressures, because positive pressure ventilation could make intracranial pressures go up. Patients who have what we call hemodynamic instability. That means issues with blood pressure, issues with cardiac rhythms, issues with heart rate, pulse rate. Those are all patients who are currently hemodynamically unstable. So for those patients, you're not going to perform IPPB therapy on. A tracheoesophageal fistula, TE fistula for short. What a fistula is just a hole or opening or communication between two different areas. So if there's a hole between the trachea and the esophagus, and you're putting this down the trachea, it can go across the esophagus. Recent esophageal surgery, X-ray or radiographic evidence of blebs. Those are very extremely fragile sections of the lung. You see those more with your severe COPD patient. Those could easily rupture with positive pressure. If they've had facial, oral, or skull surgery, if they have syngultus, which is hiccups, or nausea. This will not help them if they're nauseous. If anything, it's going to make them feel more nauseous. So maybe something to avoid, or at least avoid temporarily. Hazards and complications. Again, this is positive pressure. So positive pressure can lead to barotrauma. That's trauma to the lung itself from excessive pressures. Hyperventilation, respiratory alkalosis, same thing that appeared on the incentive spirometer. Gastric distension, that's at higher pressures. So some of that positive pressure can end up going down into the stomach. Exacerbation of bronchospasm, again, for asthma patients. Fatigue, so a lot of these similar to incentive spirometer hazards and complications. All right, so potential outcomes we're looking for here. Obvious reduction or elimination of atelectasis would be the priority here. That's why we're doing this in the first place. But with that, we should see or hear improved breath sounds, increased oxygen saturations, improvement in vital capacity levels. Their X-ray should begin to look clearer, more radio-opaque or radiolucent. More radiolucent, should start to see more air in there. Improved inspiratory muscle performance and cough. Now that we're giving this bigger, deeper, better breath, they should be able to cough more effectively. Evaluating alternatives. IPPB does require equipment, does require a special circuit, does require the IPPB machine, does require us, because we're the only ones that can give this therapy. I can't turn this over to the patient like I can with an incentive spirometer and have the patient do when I'm not in the room. No, I have to be in the room for this therapy. I'm the one performing the therapy. But before starting, determine if the therapeutic objective for this treatment can be done with simpler, less cost-effective measures like the incentive spirometer. You know, if a patient can do the incentive spirometer and do it correctly, then great, they don't need this. But if they can't do the incentive spirometer, then maybe this is the alternative. That's why I said sometimes patients get this a couple of times, suddenly they realize, I don't like this so much. I don't like being forced to take this deep breath, but I could do it on my own with the incentive spirometer. Like I said, sometimes they have this miraculous change in their technique for the incentive spirometer. Suddenly turns so much better.
So, what's the difference between this and the IPV, or is it the same thing?
It's different. It's different. We'll get to IPV a little bit later. That actually appears in the next chapter.
Okay, I'm making sure.
All right, so what I'm about to share is not in the textbook, okay? It's how to operate the IPPB machine, okay? So this is not in the textbook, but I'm still gonna ask questions about what I'm about to go over, even though they do not appear in the textbook. Again, the textbook mentions IPPB, but nowhere in the textbook does it say how to run it or how to use it. All right, so this is the IPPB machine. There are several different types of machines, but of the ones that are out there, this is the most common one. The Bird Mark 7, named after a gentleman by the name of Dr. Forrest Bird, who is really credited with the invention or creation of the first positive pressure mechanical ventilator. It's a positive pressure ventilator. So what we're talking about today really is your first introduction to mechanical ventilation. It's stuff next semester when we do mechanical ventilation class. Yes, you guys have that with me. I already know, okay, there's some basic concepts of mechanical ventilation you should already have a grasp on. All right, so it does require a closed system. It is providing positive pressure. And if the system is not closed, and what I mean by the system is not only the machine, the circuit, and the patient. If there is a leak anywhere along that circuit line or between the patient and that line, there's going to be a leak. Where do you think the positive pressure is going to go? It's going to leak out wherever that hole is, or that area is not completely sealed in. So it does require a completely sealed system, closed system. And where what generally happens to not lead to a closed system is when the patient puts that mouthpiece in their mouth and they don't keep their lips sealed around the mouthpiece and the air leaks out the side or comes out their nose. There is all your positive pressure. And there is your big massive air leak. Instead of all that's leaking out should be going to the lung. And so this will only cycle on, or excuse me, it will cycle on when the patient takes a breath. So the patient's breathing will cause this to cycle on if I've set this up correctly. It will stop, it will end inspiration when the pressure is met, providing positive pressure. But whatever the pressure setting I've set, that's when it will cycle off. But if there is a leak in the system, guess what will happen? It will never cycle off. And that's what lets me know, okay, there's a leak somewhere in the system. All right, so big picture of it. We have it in the lab. We'll see it not this Friday, but next Friday when we have our next lab. But this is just kind of some close-ups of the unit itself, looking at the different sections that you will be controlling for your patient. So this is looking at the machine and looking over at the far left-hand side of the machine. It says sensitivity here, or sensitivity effort here, with some numbers. The sensitivity control is what we use to help the patient start the breath. I'll use the term sensitivity as trigger. This is what triggers the machine to come on, the sensitivity. I need to make sure the sensitivity is sensitive enough that when the patient takes a breath in through the mouthpiece, and again, simple effort, the machine will cycle on. If I don't have the sensitivity set correctly, it could cycle on automatically when the patient's not even breathing through it yet, or I could set it where the patient's not able to even cycle it on because I'm making it too difficult for the patient to generate a breath.
So based on their breath is when it will activate?
Correct, because depending on how I've set it. Now, go ahead and jot this down because I don't think I included it on the screen here. The sensitivity setting should be somewhere between -1 and -2 centimeters of water pressure. -1 to -2. What that means is when the patient inspires, they're going to pull just a little bit, -1 or -2 centimeters of water. For example, if I set it to -20, that means the patient would have to generate -20 centimeters of force to try to cycle this machine on. And I don't want to make it that difficult for the patient. -1 or -2 is just enough so this machine knows, oh, the patient must be trying to take a breath. Not much, okay? That's the sensitivity control. Set somewhere between -1 and -2 centimeters of water. This hand timer, which is in red, can help to cycle it on or cycle it off. Now, generally, once the patient gets going with this therapy, we don't have to mess with that hand timer. Okay? It will move automatically as the patient cycles it on and as the patient cycles it off. So generally, I'm not even messing with this. But if the patient's having a hard time getting it to stop, again, they've never taken this before ever, they're not used to it, they take a breath, it comes on, all this air starts flowing, all this pressure is there, they might think, oh, I can't make it stop. Again, coach the patient, tell them what they're going to experience. You're going to feel air going into your lungs. Go ahead and let it fill your lungs, keeping your lips tight around the mouthpiece. Here's some nose clips. I'll make sure the air doesn't leak out your nose. Let it go ahead and fill your lungs. But sometimes patients will pull it out of their mouth before it has a chance to fill. Because again, they may be used to us coming in and giving them a standard nebulizer treatment. That it doesn't matter if they have a good seal or not. But with this, the first couple of times, they may think, holy crap, what are you doing to me? I can feel it filling my lungs, but I think I'm about to pop. Your lungs are not going to pop. I have said this correctly. But if I need it to stop, I just pull this handle. I just pull this red lever, and that will get it to stop. I can coach the patient, tell them, okay, what you're experiencing is not unusual. A lot of patients doing this the first time experience the same thing, but go ahead, I made it stop by pulling this lever out. Let's go ahead and start again. And maybe I have to do that a couple of times to get the patient used to it until they can kind of get it. Once they get it cycling once or twice, then they'll kind of get the hang of it, of what it feels like. Looking at the center of this unit. So that sensitivity and hand timer was over here on the left. Looking at the center of the unit. Very top thing is the flow rate control. Here, this controls the speed of the breath. How fast or how slow do you want them to get the breath? Okay. This does not control the volume. It simply controls the what?
Speed.
The speed or the flow of the breath. You want the breath to go in really quick, and give them a lot of flow. If you want the breath to take forever to finally get in there, then slow down the flow. Okay? And I want to find a happy medium. I don't want it to take too long. I don't want it to go in too quick. So kind of finding that happy medium. Again, but it's simply the speed of the breath. Question? Sorry.
Less is, or say that one more time.
The flow rate
The
control
lower,
is the speed of
the
the breath.
quicker?
The lower the flow, the longer it's going to take for the breath to get in there. The slower the flow,
okay.
or lower the flow.
All right.
The faster the flow, that breath's going to get in there really, really quick. Okay, so you need to kind of find a happy medium. I don't want it to be too slow. I don't want it to be too quick. Again, think about how you would instruct a patient to do the incentive spirometer. Slow, sustained, deep breath. So I don't want it to go too fast, but at the same time, I don't want it to take, the patients will say this, I feel like it's taking 20 minutes to get into my breath, or get into my lungs. No, it's not gonna be that long. So this is a way we control the inspiratory time. Again, that's a concept we'll talk about with mechanical ventilators, but this is how I control inspiratory time. How fast or how slow the breath goes in. So that's here, flow rate control. Now, just so you know, these numbers are simply reference numbers. They don't equate to 5 liters or 10 liters or 40 liters. These are just reference numbers, so you can tell, are we going slower or are we going faster? And again, there's kind of the mark here. Again, we'll play with it in lab next Friday so you guys can kind of see what it sounds like when you adjust the flow. Again, you turn it on really high, the breath goes in super fast. You turn it really slow, it takes a little bit longer for that breath to go in. Now just below it's the air mix control. In case you're wondering, well, this is pneumatic. This gets plugged into our gas source, God bless you, which normally would be oxygen. Okay, so this gets plugged into a compressed gas source. Again, generally it would be oxygen. I don't know if you can see this. It says pull out for air mix. This little silver knob, you will pull it out. It will mix room air into this machine plus the oxygen that you're plugged into, providing an FiO2 of approximately 40 to 60%. Now you may want to jot that down somewhere. The air mix control, if I pull this out for the air mix, the FiO2 provided is going to be somewhere between 40 and 60% oxygen. 40 and 60% oxygen. Now if I push it in, that eliminates the air mix, meaning it gives 100% of the source gas, which again, if we're plugged into oxygen, that means what FiO2 will it provide? 100% oxygen. So depending on what my patient needs, or what my patient, I should say, is right now on, oxygen-wise, Do they need a FiO2 of 40 to 60, or do they need an FiO2 of 100? That's gonna determine whether I use this air mix or not.
So you pull it out, it's gonna be 40 and 60?
Correct.
And push it.
And push it in, we'll give 100%. Okay. Again, you will see what it means to push that in or pull that out next Friday when we do this in lab. Okay, but this is how you control your FiO2 with the machine. They're either getting what? 100% if I push that button in. If I pull that out, they're getting an FiO2 of 40 to 60%. Nothing else. No other in between.
So,
Okay.
when you pull out, there is like something that keeps it open, or it's just pull and goes back?
You'll
to
see,
place?
there is some, it's kind of a hard thing. When you pull it out, it stays. It's not gonna get,
Oh, okay.
it's not gonna
So it
get
keeps
forced
mixing.
in unless I physically push it in.
So it keeps mixed, so like,
Yep.
okay.
Yep.
Yeah.
Right.
So like whenever you say 40 to 60, like whenever you pull it out, is there like levels that you can be like, okay,
It's
I'm
somewhere
pulling out
between 40 to
partially, it'd
60.
be 40 and then
No,
all the
no.
way it'd be 60?
Nope. It's somewhere between 40 and 60. Again, it's not a device that's meant to deliver a specific oxygen. And again, it's only during the treatment, only during this therapy.
Okay.
Which again, this therapy could take 10, 15 minutes to do for a patient, just depending. So this is, again, depending on whatever my patient's FiO2 need is right now. Let's say it's one of you guys, you're on room air. Okay, well, unless I have this plugged into room air, for you guys, I go ahead and just pull this out, give you 40 to 60%. You don't really need that extra oxygen. But if right now you're on a non-rebreather, high FiO2, I'm like, I'm gonna have to take you off your non-rebreather to give this therapy. Let's go ahead and, in this example, push it in. So it's giving you 100%, God bless you. Giving you something closer to what that non-rebreather is providing. So really it depends on what the patient is on right now. If they're on a 2-liter nasal cannula, I'll use the air mix, I'll keep it pulled out. I know a 2-liter cannula is only 28%, right? Not anywhere near 40 to 60, but that's all I would be able to do for that particular patient during the treatment, during the therapy only. All right, just below that control, so there's 3 controls here on the front. Last thing here, they call it the expiratory timing device. And do you see what it says here? For apnea. Now we're talking IPPB as a therapy, lung expansion therapy. If I'm using it for that purpose, keep it off, turn it off. Make sure it's in that full off position. You turn it all the way clockwise to the right, which is not a very far turn, to make sure it's off. Now here's the other thing, if I needed to use this as a ventilator, not IPV treatment therapy, I need to use this as a ventilator, I'm gonna turn this on. Again, I didn't design this, I didn't come up with this terminology. This is how you set a respiratory rate with this machine. If you want it to come on every so many seconds, this is how you would do that. That's why make sure you keep it turned off for therapy, because even if you keep it on ever so slightly, guess what's gonna happen? It's gonna come on every so many seconds, whether the patient's breathing through it or not. And so always make sure this is turned off for IPPB therapy. All right, everybody okay with sensitivity, hand timer, flow rate, air mix, expiratory timer, but that one's easy because you're just gonna make sure it's turned off. You're not even gonna use that. Also on the front is a pressure gauge. Remember, this provides positive pressure. So when it cycles on, you will see this pressure gauge go up to whatever pressure you have set. Okay, whatever pressure you have set, you'll see that pressure gauge go up. On this negative side, what's kind of in this pinkish color, what did you set the sensitivity to? -1 or -2. When the patient starts the breath, you will see this go back approximately only -1 to -2 before it begins to cycle on. If you were to set the sensitivity inappropriately at -20, you have to pull back all the way here before the machine will ever cycle on. You've made it way too difficult for the patient to initiate the breath. So I only set it to -1 or -2. And this is what visually you would see them cycling the machine on with. So you'd see that pull back just ever so slightly negative before then the pressure goes up positive to whatever the pressure was that you have set. All right, so how do you set that pressure? That's what's on the far, okay, there was the gauge, there's the pressure manometer, sorry, I forgot I had a zoomed in picture of it. But on the far right of the machine is where you set the pressure. This is where you set the pressure. This is how you control the volume that's being delivered. So there's not a knob or a dial or a gauge that you program in a tidal volume. This is a positive pressure machine. So what you're delivering is positive pressure. By giving them more positive pressure, guess what happens to the volume that's being delivered? The greater the volume that's going to go into that patient. So instead of you seeing a control that says 500 mLs or 600 mLs, you're not going to see that. You're going to see a pressure that you can provide. And so let's just say I set it to 15, because that's the number that's closest to me right now on the screen. That means when the pressure goes up, it's going to go up to 15, and then what's going to happen? It's going to stop and shut off and go back to 0 until the patient takes another breath. You keep inching that pressure up from 15 to 20. Now that gauge is going to go up to 20 before it ever cycles off. The greater the pressure, the greater the volume inside the patient's chest. The lower the pressure, the smaller the volume going inside that patient's chest. All right, so regarding inspiratory pressure, this is an important number to remember. Never, ever, ever setting that pressure higher than 20 centimeters of water. 20 centimeters of water is the max. I generally tend to start out a little bit lower on a patient until they get used to it. Once they get used to how to cycle this on and off, then I'll slowly start tweaking that pressure up a little bit higher, a little bit higher, a little bit higher. But never going higher than 20. 20 is the max. You guys do this to each other in the lab. I'm emphasizing this because we don't want to have to call 911 and have anybody come out because somebody's just thrown a pneumo. Don't let the pressure go higher than 20. Our lungs could handle it. Our lungs are compliant. But our patients, we don't want to risk it. Never going higher than 20 centimeters of water.
So now when you set the pressure, the higher the pressure, that decreases in the lungs, or does that?
No, the higher
It's
the
reversed,
pressure,
right? So-
the higher the pressure, the more pressure you're putting into the lungs.
Yes, okay, so.
Translation, greater volume.
Okay,
You're
and then
putting in the lungs.
the least is.
Lower
okay.
volume. Yep.
So the pressure that this is reading is like the pressure that's being like exerted back out, because you're holding up the mouthpiece. Like,
No, that's the
That would
pressure
be
that
what-
we're forcing in.
So that's the inhalation, so that's the
Yep.
pressure you're putting into your,
Yep.
okay.
Yep. That's the pressure we're putting into that patient's chest. That's the pressure we're putting into that patient's lungs. Is that pressure setting. Once that pressure is reached, what happens to the positive pressure?
Shuts off or stops?
Shuts off. That pressure then goes back to 0. And it's the passive recoil of the lung
So it's basically
that
like
allows
the-
exhalation to occur.
So is it basically like the assist, like to breathe? I mean, not,
So, no, you're on the right track. So imagine I've had surgery. I've had open heart surgery. And it hurts like heck for me to take a deep breath, and I really can't do your incentive spirometer very well. But you come in with this.
Mhm.
You go, okay, John, all right, we're gonna do some positive pressure. Here's that pressure. Here's 20 centimeters of water. All that pressure is going into my lungs. Translation, more volume going into my lungs.
Yeah.
Once that pressure is met, then what happens to the IPV machine as far as positive pressure? Turns off. That pressure went from 20, turned off, went to 0.
Does the-
And it's the passive recoil of the lung that allows me to now exhale until I'm ready for my next breath.
And then
Boom,
exhale.
here comes positive pressure again.
does it also help with exhale, or that's all
No,
on you?
That's
them
the
doing
patient.
that?
That's the patient's natural recoil of the lung
Okay.
to allow exhalation. So this isn't pulling anything out of the patient. It's normal recoil of the lung that causes the patient to
Okay.
exhale. This is strictly inspiratory positive pressure umph. You've all bagged,
Yeah.
even the mannequins, right? At some point, CPR
I
class,
was
you've
really
all
fixing
bagged.
to say that.
That was positive pressure you were providing on the mannequin lung.
Okay, I get it.
So like a patient with like a low compliance lung is going to have less volume, but it's the same amount of pressure. But
Yep.
like somebody with a high
It's
compliance.
very perceptive. Yeah, not getting so much into that just yet, because that will come in time. The question was, well, what if my patient has very low compliant lungs? That pressure is going to be met so much quicker, and the volume for that patient is going to be a lot less than, say, you and mine with a normal compliant lung. That is so true. That is so true. But that's a mechanical ventilation concept we'll get to next semester in time. But for right now, I'm just thinking us with decently compliant, normally compliant lungs. You want to make that patient to do a larger volume, give them more pressure. You want them to do less volume, give them less pressure. Again, that's why it's intermittent PPB, positive pressure breathing, because that's what we're providing them. All right, additionally, there's going to be large bore tubing circuit connected to the machine. The other end's connected to the interface that the patient will breathe through. There's also small bore oxygen tubing that will be connected. That small bore tubing, so the corrugated tubings here going to the mouthpiece or mask, whatever I'm using. There is a nebulizer cup that can be added here. That is part of this therapy, so medication can be added. So not only do they get the positive pressure breath, but I can give them some medication as well to help open up the lungs. When the patient exhales, they don't exhale back into the machine. They exhale here. God bless you. There's an exhalation port here, so they will exhale. Wherever this is pointed is where their exhaled breath will go to. So I always point out that to you, because you're generally holding it here to the patient who's over here. What if I was on the other side of the patient and I had that turn just perfect where it's blowing right at my face? I'd point it down, I'd point it away, somewhere where it's not blowing or blowing back right at the patient's own face, but generally pointed down or at least away from us. Now this small bore tubing does go back here, so that small bore tubing is what powers the nebulizer and also powers this exhalation valve. So when the patient does exhale, the breath escapes here. Okay, so that's what the small bore tubing, that's part of the system. It has to be connected. Without it, it would never cycle off. Obviously the circuit has to be connected. If not, it would never cycle off. Again, how it would appear when the patient's breathing. Yes, you can listen to breath sounds. Obviously before the patient receives therapy, after the patient receives therapy, while the patient's receiving therapy, you can actually hear the air going into the lungs. Maybe you're hearing air going into the lungs where it never was before you were given this therapy. This gentleman seems to be doing it okay. He's not wearing nose clips. Hopefully a tight seal around the mouthpiece here. If the patient wasn't able to provide a good seal, they have these flanges that can go over the mouthpiece. Kind of looks like a football player's mouthpiece to kind of try to prevent any air from leaking out. If that alone doesn't work, we could use a resuscitation mask. And now we have to make sure we have a good seal holding it on the patient's face. If we didn't have a good seal, guess what? The air is going to leak out and the machine will never cycle off. Remember, it has to be a closed system, leak-free system. If it's with a mouthpiece and it won't cycle off, I bet you the air is leaking out the patient's mouth or it's coming out their nose. That's where we can use nose clips as well. That's generally where we would end up seeing a leak. And again, how would I know it's a leak? Machine cycles on, but it never cycles off. If it never cycles off, that means there's a leak somewhere in the system. I don't have it pictured here. You can even have an adapter to connect this to a tracheostomy. So we can still provide IPV therapy to a tracheostomy patient. The only catch is, because that's to be a closed system, that tracheostomy cuff would have to be inflated. So if they don't have a tracheostomy cuff, if they have a cuffless tracheostomy tube, then it wouldn't work because air would be leaking out.
Would you be able to plug that and still use it regularly, or?
If you had a cap to plug it over, that could work, and then use a mouthpiece or the resuscitation mask. Again, to create the closed system. All right, so quick review. And these are some good questions I could ask. What happens when you adjust the flow rate? What happens when you adjust the flow rate on IPV? Speed of the breath. How fast or how slow the breath will be delivered. Inspiratory pressure, what does that adjust or control? The volume being delivered. What does the air mix do? FiO2. If I have that knob pushed in, what FiO2 am I providing?
100%.
100%. If I have that knob pulled out,
40
to 60%. What is sensitivity?
The trigger.
That's the trigger. That's what helps the patient cycle it on. Okay? The sensitivity is what makes it cycle on. So for example, here's a troubleshooting question. You're doing IPUB to a patient. You hand the patient the circuit, the mouthpiece, everything's plugged in the way it's supposed to be. The patient appears to be breathing, but the machine never cycles on. What's the problem? You probably have the sensitivity set inaccurate, inappropriate. Okay, where should the sensitivity be set?
-1,
-1, -2, -1, -2 centimeters of water. If patient's performing IPVB and it's cycling on and off like it's supposed to, but you feel that the patient isn't taking a deep enough breath with it, what could you adjust? Inspiratory pressure. Okay, so let's say it's set at 10 centimeters of water. Can I go higher than 10? Up to 20. 20 is the max. 20 centimeters of water is the max. If IPVB is cycling on and off the way it's supposed to, but inspiration seems to take too long, what could I adjust? I could adjust flow rate. Again, if inspiration is taking too long, that means you need to increase the flow rate to get the breath in there even faster. Just a few troubleshooting type questions. Anything else that's on here that I need to talk about again? Mention again? I know when you're in front of it in the lab, we'll mess with all three of these things and talk about them in lab. Not this Friday, but next Friday, so you guys can kind of see that stuff in action. Again, this is what controls the volume. This is what helps to start the machine. What does it mean if the machine starts okay, but it never stops? It never cycles off. There's a leak somewhere in the system. Somewhere in the system there is a leak. All right, everybody okay with IPUB? Oh man. Okay, so kind of getting back what's in the textbook last little bit here. Other lung expansion techniques. CPAP therapy can even be thought of as a lung expansion therapy. Continuous positive airway pressure provides a continuous distending pressure to keep the alveoli open and distended. Hopefully recruited if they're at risk for atelectasis, or if we're trying to fix or reverse atelectasis, that positive pressure, just like we talked about with IPPB, right? To provide an opening to keep those alveoli open with. Different ways we can do CPAP, even just exhaling against the threshold resistor. Pressure is approximately 5 to 20 centimeters of water, are typically what could be given here with CPAP therapy. But let me say this. CPAP therapy, it's pressure, positive pressure. IPVB, positive pressure. If someone's on CPAP therapy, the pressure is always there, right? They can still breathe in and breathe out, but the pressure is always there. IPPB, there is no pressure until they take a breath in, and here comes the positive pressure. The knock on IPPB as being an effective therapy or treatment for atelectasis is it does a good job during the therapy. And how long did I say the therapy lasts for IPPB? 10, 15 minutes tops. The drawback is with IPPB is once you finish the therapy and now there's no more positive pressure, what about the atelectasis? It could come back. CPAP therapy, so taking this and going, well, maybe this could be more advantageous for the patient with atelectasis, is guess what? It's always there. If someone's on CPAP, until they take that mask off or we disconnect them, they're always on that positive pressure. So that may be a way, again, a little more, I don't want to say invasive, but a little more aggressive than, say, your typical incentive spirometer. IPB is a little more aggressive than a simple spirometer. CPAP, a little more aggressive than a simple spirometer. But the patient's always receiving that positive pressure to keep the alveoli open. Whereas IPVB, it's temporary. It's in the word IPVB, it's intermittent. You know, if I'm only going in there to do a IPVB treatment every 4 to 6 hours, then okay, during those 4 to 6 hours interval, it's working, but what about those times in between? Contraindications, hemodynamic instability, patient with hypoventilation, nausea, of course, facial trauma, untreated pneumothorax, elevated. These are all very similar to the positive pressure contraindications to a patient receiving IPVB. I would say with different, the facial trauma, because this mask has to be kept snug and tight on a patient's face. Hazards and complications, these are also very similar. Barotrauma, PTX, my abbreviation for pneumothorax, hypoventilation, gastric distension, risk of what if the patient was to vomit and they're wearing one of these things? You know, are they able to get it off their face fast enough? Do they even know how to take it off their face quick? A lot of them do have quick release type things instead of having to unsnap the Velcro. For a patient, I could teach the patient how to quickly take it off if they were going to get sick. But if they were to get sick and they have all this positive pressure coming, guess what? That vomit doesn't get forced back down into the lung. Jared?
That's why in my hospital, this is probably across Florida or anything, but if they're restrained, or if they're like restrained, they can't use that. Because if they vomit, they can't actually take it off.
Right. Some places, to add to that, some places will say it's mandatory to put a nasogastric tube to make sure there's no stomach contents down there. That if they were to get sick, they basically just dry heave and not worry about aspirating anything. But again, things that we would need to be concerned about. And then pressure ulcers, but that's from the mask.
So you can only use like that type of mask or interface when you're doing the CPAP for positive pressure? Because when you're doing the CPAP, you can use like different interfaces per patient.
Oh, yeah, because this CPAP's the same CPAP like a patient on home CPAP for sleep apnea. Same sort of therapy, except the patient in the home, they could have just the nasal prongs, and if that patient was to get sick, obviously there's nothing prohibiting that. This is a little bit more, and so they typically have a full face mask covering both the nose and mouth. The reason I would say we probably wouldn't be the best to use just a nasal interface with this form of CPAP is because, sure, that can provide positive pressure. And again, remember why in this example we're saying we're using it is to treat a reverse atelectasis. If they have nasal prongs, the second they open their mouth, where's the pressure go? Out, right out. And so that's why kind of covering both the nose and mouth here. But again, obviously greater risk of them perhaps vomiting, aspirating, that stuff. Last bit here, positive airway pressure therapy. So again, providing positive pressure increases the transpulmonary pressure gradient, enhances lung expansion. But with this type of therapy, PAP therapy, which sometimes could be also tied into PEP therapy, positive expiratory pressure therapy, no using complex devices, no, not needing equipment, or equipment that needs to be plugged into something, like a pneumatic gas source, for example. So these could be smaller handheld devices that can provide positive airway pressure. PEP therapy is an example, positive expiratory pressure devices. Flutter valve is just simply an example of one, and the textbook even mentions CPAP again here. These are forms of providing pressure to a patient, but where you end up seeing these more used is what we're going to talk about in the next chapter, because we typically use these to provide positive pressure to kind of help loosen, jostle up secretions to make it easier for the patient to exhale and remove secretions with. But these positive airway pressure devices, or PEP therapy devices, positive expiratory pressure devices, can help recruit alveoli, increase FRC, decreased work of breathing, God bless you, improve distribution of ventilation through those collateral channels of ventilation, like the pores of Kohn or the canals of Lambert. In this particular picture, this is supposed to represent a mucus plug. Here's a normal alveolus. If we can use positive pressure, so that positive pressure maybe that pressure can go through that pores of Kohn or even the canals of Lambert to help reinflate that alveoli so that alveoli can sit there and clear that mucus plug. And so again, we just corrected the atelectatic alveoli here by simply using one of these devices. So with that, you can also increase the efficiency of secretion removal. It's why you see these will appear, and I'll talk about these a lot more in depth in the next chapter, chapter 44, is where these things really tend to be used as a means for secretion removal. All right, when selecting an approach, again, for lung expansion therapy, choose a modality that's the safest, simplest, and most effective for that individual patient. I know, and I'm as guilty as anybody else, I have my own personal favorites. And when I see a patient present a certain way, I want to give them my personal favorite. But maybe that's not what's best for that particular patient. So I can't tailor every patient to like or to use what I prefer. I need to find what works best for that individual patient depending on how they are appearing, what they are showing me. So, for example, the patient isn't having issues with secretions and their vital capacity is greater than that minimum mark of 10 mLs per kilo, then how about we do incentive spirometry? Incentive spirometry would work well for most individual patients. But what if they can't do this mark? They're less than 10 mLs per kilo. Then maybe that's the patient that has to receive the IPBB. If they have excessive sputum, and that's what's leading to the atelectasis, then maybe that positive airway pressure or positive expiratory pressure therapy would be best, using that in place of the incentive spirometer. If everything else doesn't appear to be working, then maybe CPAP, because it's continuous. It's always going to be there, that positive pressure. Maybe try CPAP. And always don't forget about that mobilization, making that patient ambulate. So we can use a combination of things sometimes. Yes, incentive spirometry, plus don't forget getting that patient up out of bed, getting them walking, get them ambulating as soon as possible. Any questions? Any questions? Lung expansion therapy. So I'm sure you've had questions up to this point, and I've maybe inferred to some things going, oh, well, grandma can't take very deep breaths, or this patient can't move a lot of air, and we have some therapies we can do for that. Well, guess what we just talked about? We talked about those therapies we can do for those particular individual patients and those individual situations. When you have that patient who you just wish they could take better breaths, deeper breaths, and you wonder, well, I wonder what other therapies. Can I give them a bronchodilator? Can I give them their albuterol neb? Are they wheezing? No. Well, then albuterol is for wheezing. That's not going to be the appropriate thing. If they need to take better breaths, deeper breaths because they're just not taking deep enough breaths right now, think about lung expansion therapy. I'm not saying we have to start with IPBB, but think about the lung expansion therapies. Maybe some of those therapies are what we can try with this particular patient to get them taking deeper, better breaths. All right, let me give you some questions. I think I asked 4, unless I changed them. No, 4 questions right now, 4 questions. All right, the first one is this. How would you instruct a patient to perform an incentive spirometer? Let me read them all, don't blurt out the answer. First one, after a full and complete exhalation, take in a slow, deep breath through the device, ideally with a breath hold. Number 2, or B, exhale completely through the device as fast as you can. C, after a resting exhalation, take in a slow, deep breath through the device, ideally with a breath hold. Or D, inhale and exhale deeply through the device as fast and as deep as possible. What is the correct answer? C. C is the correct answer. A sounds really good, and just like I like to do with my test questions, I try to throw in A being something that sounds really, really dicing and really tempting to make you not read the other answer options. Okay? A doesn't sound too bad until you read C and go, oh yeah. You're supposed to exhale normally, not exhale full or completely prior to taking in that deep breath. So C is the correct answer here. C is the correct answer. Everybody okay with that one? So if I ask this question on the test, you'll get it right? Yeah. You said yes. I'm just saying. You said yes.
Saw a video.
All right, next one. What's the minimum vital capacity in mLs per kilo that a patient must achieve for incentive spirometry to be effective? Is it 20, 15, 10, or 5 mLs per kilo? The minimum vital capacity. 10. Make sure you remember that number. 10 mLs per kilo. And I know in this program there's 1,000 numbers you have to know and remember. We just actually did this last week with the second year class, reviewing some of this information. And I know I got some of them with that 10 number. Again, think about the second year, how many numbers they have to know versus what you guys had to know already up to this point. Again, it's one of those numbers you tend to forget about over time. So remember, 10 mLs per kilo is the minimum. But what is yours? What is mine? 65 to 75 mLs. Just to put it in perspective, that 10 is really not much of anything, when normally we could do a whole lot more than that. All right, so this one was C. Next one, what do you adjust to increase the volume a patient receives when performing IPPB therapy? Is it A, increase the flow rate setting, B, increase the pressure setting, C, push in the air mix control setting, D, lower the sensitivity setting, or E, you cannot increase the volume delivered during IPPB therapy? Boo boo. More pressure. More pressure. B is the correct answer. More pressure means more volume. Less pressure, less volume. And like I said, I know sometimes in here we're talking about things, well, I wish I could see it. You will see it in lab. And don't let me or Desmond forget. If we forget to mention, well, how do you make the volume go larger? You guys ask it. Help us remember to remind you guys that. We will set these things up. We'll set them up to test lungs. And you'll see the test lung expanding. And please ask the question, well, what if we want the volume to be more? Again, you should know already, increase the pressure. Let's increase the pressure, and we'll see that the test lung go even larger. Or you really turn down the pressure really, really low. You'll see the test lung barely inflate. All right, I think I have one more here. What's the control that helps the patient trigger a breath on an IPPB machine? Is that sensitivity, air mix, pressure, or flow rate control? Again, helps the patient trigger a breath. That is the sensitivity. They're having trouble triggering a breath, and it's plugged in. I guess that's the first thing. Make sure it's plugged in. It is plugged in, and they're having trouble starting a breath, then it's the sensitivity that you need to fix or that you need to adjust. And that was my last question. All right, any questions for me? No? Second to the last chapter. We only have one more chapter left, and I do split it up into two parts. All right, so I have 11:17 right now, nearly 11:20. Why don't we still start at our normal 12 o'clock time? I do have a part 3, if you looked already in Canvas, the part 3 PowerPoint. And I apologize, I should have had the foresight to even suggest this. And I know many of you probably already have done this, but because I've given you those PowerPoints, I've already given you the blood gas examples. If you haven't had a chance to interpret, I would say before we start the next class, go ahead and take a few minutes and see if you can interpret those blood gases. So when we go over them, this is not the first time you've seen them. Okay, that you know what the slides are. See if you can interpret it right now. That way when we go over it, in case I get going too fast, because I talk fast and I get all excited and pumped up, especially when I'm talking about blood gas interpretation, give you a chance to already have interpreted